Thank you so much for joining us today as we mark World AIDS Day with this special event. Hopefully, you will find it engaging and informative and also provoke questions and spur action. I want to acknowledge that today I'm speaking from Vancouver, and it is the unceded ancestral lands of the Musqueam, the Squamish, and the Tsleil-Waututh nations. I would also like to recognize that we are gathered here from all around the country, that each of you are on different traditional territory. And I'd like to pause for a moment if anybody would like to speak out their land acknowledgement, or perhaps you want to put your land acknowledgement in the chat box. Okay, it sounds like people will put it in the chat box. So moving on, this year marks 40 years since the first case of AIDS was reported. While we have the tools and knowledge to address HIV and AIDS, the world is failing to meet many of the targets set out by the international community as we now enter the 5th decade of the pandemic. In Canada and around the world, persistent and unaddressed social and structural inequalities continue to confound efforts to address the crisis. In the past 2 years, we've also witnessed the impact of these inequalities as they have been further exposed and exploited by the COVID-19 pandemic. Aligned with the UNAIDS theme of end inequalities, end AIDS, and pandemics, the CTN is excited to offer a diverse set of speakers today so that they can discuss the important topics that we are facing today. I'd like to introduce the host of our event today, Sherry Margolyes, the community co-lead of CTN's Cross-Core Community Collaborative. Sherry has been an active voice for people living with HIV since her diagnosis in 1993. In fact, she was one of the first people in Canada to go public with their HIV status. As a mother, her advocacy and education effects have often focused on the needs of women and families living with HIV. Sherry has served in many different leadership roles in the community, as well as advocating for the meaningful involvement of people living with HIV in the research project, including a previous role as chair of the CTN's Community Advisory Committee. As you all know, the CTN from its very inception involved and worked with the community, and then we had a Community Advisory Committee from day one, and that committee has made a huge contribution to what we are today. In fact, the whole world is looking at how we have succeeded in working with the community. Sherry is a freelance writer, public speaker, and community consultant with expertise in knowledge translation and community-based research. She has been awarded the Golden Jubilee Medal of Queen Elizabeth II and has received other honors for her contribution and dedication to the HIV community. In her spare time, Sherry enjoys beach walks, her dog Ruckus, and spending time with her family and friends. Thank you, Sherry, for being our investigator and for hosting this event today. And I want to thank all our speakers here, friends, colleagues, and co-conspirators in the Canadian HIV Trials Network for many years. Thank you so much for giving of your time and participating in this event. Over to you, Sherry.
Thank you, Aslan. I appreciate your very generous introduction. I'm just going to share my screen here, and it's my pleasure to host this what we call a cross-core collaboration, which means different areas of research, including social science, basic science, epidemiology, and all other community-based research. And we're all here with you today. I would also like to share my land acknowledgement. I'm joining you today as a settler from the shores of Lake Erie, the traditional land of the Three Fires Confederacy, the Ottawa, Potawatomi, and Ojibwe, which is known as Chatham-Kent today in southwestern Ontario. Chatham-Kent neighbors 3 major nations, the Delaware Nation, Walpole Island First Nation, and Caldwell Nation, and is home to a diverse First Nations peoples and Métis people. I'd like to honor and acknowledge the traditional people of this land and recognize our collective responsibilities to the land, water, and people here and across Turtle Island. I invite you to reflect upon this land acknowledgement, what it means to you, and how you are upholding the Truth and Reconciliation Commission's calls to action. If you haven't already done so, please feel free to share your reflections and acknowledgements in the chat. Today is World AIDS Day, and World AIDS Day is a day when we remember those who we have lost to HIV and AIDS, reach out to people living with HIV, reflect on the impacts of HIV worldwide, celebrate our accomplishments to date, and look forward towards a world free of HIV and AIDS. These past few years have been challenging for people living with HIV, like myself, as the death, stigma, and politics of the COVID pandemic trigger us to recall the harsh realities of the early days of AIDS. As Dr. Annis mentioned earlier, this marks the 40 years since the first case of AIDS was reported. Next year will mark my 30 years, and I get emotional when I talk about that because it's such an amazing amazing thing to be marking 30 years since I was diagnosed with HIV along with my infant son. The early days of the pandemic were fueled by inequality, homophobia, sexism, racism, and as well as stigma, both of which persist today, unfortunately. In my 30 years, I've personally experienced the death of countless friends and colleagues and faced my own mortality and that of my son. There was no treatment in 1992, and there was no hope. Along with my peers and colleagues, scientists and allies around the world, we fought for the last 40 years, some, and 30 years myself. We fought for access to treatment and against stigma and discrimination. Although the fight continues, activists and scientists, allies have made huge strides in the areas of care, treatment, support, and towards a cure for people living with HIV. For myself and my family, we defied the odds. Woo! You can practice so many times, but World AIDS Day brings out really can bring out emotion for a lot of folks, not just me. Just last week, my son celebrated his 29th birthday alongside his 2-year-old son, my grandson. And this is a day just 30 years ago, I never thought I would see. So please take a moment to remember those people who we've lost, people living with HIV, and those who have supported and fought for us. Okay, and I'll pull myself together while you do that. So today, we're going to discuss recent advances in vaccines for HIV, what we have learned about COVID-19 in people living with HIV, and the pervasive impact of social inequalities on our collective goals. Dr. Rupert Kaul will discuss the latest developments in the pursuit of HIV vaccines, as well as the possibility of a functional cure. Doctors Anne Burchell and Cecilia Kostiniak will describe the research that's being done to assess the effectiveness of the COVID-19 vaccine in people with HIV, along with confidence in the vaccine as well. Dr. Pascal Diadou will be discussing the intersection of COVID-19 and the HIV/AIDS pandemic through the lens of social determinants of health. It's my honor and pleasure today to introduce our first speaker, Dr. Diadou. Pascal is a bilingual part-time assistant professor at McMaster University. He's in the Department of Health Research Methods, Evidence, and Impact. Dr. Diadou is also a research analyst and methodologist. He's a consultant at the Dalai Lama School of Public Health in the Department of Social and Behavioral Sciences at the University of Toronto. Dr. Giadu's research primarily focuses on HIV implementation science, health inequities and disparities. Starting this winter, he's going to be lecturing applied epidemiology at the Faculty of Health Sciences and Wellness at Humber College in Toronto.
Thank you so much, Sherry, for the introduction. So I'm going to be talking today on inequity and disparity in COVID and HIV. So I've tried to find the intersection between HIV and COVID and the factors that actually make things worse, in time of pandemic like COVID-19. So first of all, I would like to share this couple of picture here. As you can see in the left, as Whitehead in the concept of principle of equity and health define equity as a moral and ethical dimension. It refers to differences which are unnecessary and avoidable, but in addition are also considered unfair and unjust. If you look at the picture on the bottom left, you can see that that's far left, there's liberation, meaning that, everything could be equal, but equity is more than equality. So in fact, equity is completely different from equality. Liberation means we could remove the barriers to make sure no matter the height, no matter the weight, that everybody have access to healthcare in this context. So now I was searching the net and come across several pictures defining COVID-19 and HIV as the new pathogen and the same disparity. Mostly the community of color and also HIV, same script, different virus, HIV and COVID-19 in the US Black community. And also the impact of HIV treatment and research, a call for action. So now I would like to talk a little bit about the direct and indirect consequences of COVID-19. Health and well-being in Canada has always been non-equal or unequal before COVID-19, mostly due to public health measures, structural determinant of health, stigma, social cohesion, intermediate determinant of health. So now the social determinant of health could be the condition, the environment where people are born, live, learn, work, play, worship, and that affect a wide range of health, functioning, and quality of life outcome and risk. They include income, education, employment, housing, gender, race, disability, immigration status, spirituality, social safety, and also geography. And geography has been very important in the time of COVID, where depending on where you live and where you work, you could be more exposed to COVID-19 infection. So now the COVID-19 pandemic revealed the systemic inadequacies that produce health disparity. We talk about the disproportionate burden on vulnerable population that were already existing during the HIV pandemic. And the United Nations report has indicated the increase in food costs and market stockpiling that has been harmful for some of these communities. The vulnerable populations with stigmatized and marginalized intersecting identity often experience the highest burden, including MSM, transgender women, people who inject drugs, commercial sex workers, etc. And those are all determinants that we saw in the HIV pandemic. That's also very affecting people in the COVID pandemic. Also, we have to talk about immigration and displaced people, in terms of HIV and COVID. Now, I think it's important to highlight the structural racism that's operated through the social determinant of health, because if you look at COVID and HIV, the intersection and where both both pandemic kind of joined together is this structural racism and structural violence as well as colonialism. And they go to the social determinant of health. We talk about pre-existing condition, social and economic disparity, and has been highlighted. You know, the living condition that puts some people at risk, and that includes essential worker, job insecurity and lack of paid 6 days, need to commute on crowded public transportation, and living in crowded housing. So in Toronto, 53% of people hospitalized due to COVID-19 could be considered low income. And the divide has been due to systemic racism, other discrimination that creates unfair barriers to opportunity, health, well-being, safety, fair treatment, and resources. This is according to Public Health Ontario. Now, to illustrate that, we can see on this chart how the impact of COVID has been significant in ethno-racial groups. And if you go from the left to the right, you can clearly see that Middle Eastern, Black, East Asian, Latin American, and South Asian, just to name a few, has been, in terms of their overall population in Toronto, more affected on COVID than other specific population. So the factor associated has been racialized and income that have been affecting this population a little bit more. So addressing inequity in COVID-19, and the public health, Toronto Public Health developed strategies to address that. That includes focusing on specific neighborhoods where the infection of COVID has been significantly high, expanding vaccine access and reducing barriers, expanding access to COVID testing, sharing public health information, providing support for isolation for those unable to safely do so at home, addressing other socio-economic impact of COVID, and long-term planning and advocacy for a more equitable system of health and social services. Now, talking about vaccine, and I think Rupert is going to elaborate a little bit more on this. In Ontario right now, 86% of the eligible population over 12 years of age has been vaccinated, but a huge disparity remains. While Canada is one of the countries where the vaccination rate is high, 66%, we still have South Africa with 24%, Nigeria and Ethiopia with less than 2%, India 32%, and Indonesia 35%. So the disparities still remain, and nobody is safe until everybody else is safe. So in terms of vaccine hesitancy, a study by Philip Gersten kind of illustrates, you know, the variance in vaccine hesitancy. 38% is associated to lack of vaccine confidence, 21% of complacency, 30% of social demographic, and 11% social psychological determinant. So the factor associated to this vaccine hesitancy is mostly mistrust of the vaccine benefit, lower perceived seriousness of COVID, right-wing political affiliation. The socio-demographic include younger age, women, race, employment status. So I did a couple of webinars through an organization I co-founded called Global HIV Information System. And what we came across as a result in terms of information on vaccine is that all those 40% of those who attended some of the seminars were not vaccinated. Their reason were personal reason, experimental vaccine, people should not be forced to take vaccine, the government do not want to take responsibility, people were not well informed, and most of the people who responded who were hesitant to take vaccine talk about the trust to the government. Now, I wanted to finish this talk by talking a little bit about a study we did in Toronto and Ottawa looking at the epidemiology of HIV in the African, Caribbean, and Black. So it's important to say that ACB people constitute 5% of the population in Ontario and account for about 25% of new diagnoses of HIV-1. So the aim was to measure the prevalence of HIV in this population and facilitate and improve understanding, associated behavior, knowledge, community structural factor, and healthcare access and utilization among this community. So the primary objective was where the prevalence of HIV, behavior associated with HIV transmission, testing, behavior of HIV, core knowledge, and key individual and structural factors. So we got 1,380 ACB people between 15 and 64 residing in Toronto and Ottawa. And in terms of sexual practice and sexual health, 1.7% and 3.1% respectively has given drugs, money, goods, and service in exchange for sex. Having multiple partners and condoms and level of condom use were associated to HIV risk. Substances, mainly alcohol and marijuana, were commonly used during penetrative sex. So the implication for policy and practice is that policies and institutional practice are stronger determinant of HIV with infection. The economic, legal, and social factors and the prevalence of HIV and STI within the sexual network were some of the reasons for transmission. And we also need to address structural factors that increase vulnerability to HIV. So key action, we have to estimate the prevalence and incidence of HIV in this community, estimate the level of virus suppression, that's important, provide education, address structural disadvantage, increase the availability of access to HIV-related information, address stigma and barriers, and share information about HIV, and as well as raising awareness. So some of the key findings were that 80% of people living with HIV in this community were under the care of health professionals, 88% were taking prescribed medication, and we still have 7% who were diagnosed within the last year or so. Now, one thing is that all people living with HIV should have access to HIV care medication. We have to promote PrEP and HIV prevention, tool for ACB, remove socioeconomic barriers to access PrEP and PEP, collect synthesize existing data to assess how ACB communities are doing along the 1990 cascade, guarantee access to HIV care treatment regardless of residency, status, or other factors. So we talk about immigration, HIV, and also it's important to highlight that to tackle HIV in the ACB community, we have to focus on social and structural factors, the inequity and anti-Black policy that also generate harms in Black communities. So despite Canada having 2 languages, we found in the study that French-speaking ACB people face an additional disadvantage due to language barrier. Thank you.
Now it's my pleasure to welcome Dr. Anne Burchell. She's a CTN investigator who is the co-leader of the co-infections related conditions core of the CTN. Dr. Burchell is an associate professor in the Department of Family and Community Medicine and the Division of Epidemiology at the Dalai Lama School of Public Health at the University of Toronto. She is a Canadian research chair in sexually transmitted infection prevention with a research program that focuses on a variety of sexually transmitted infections, including HPV, syphilis, and of course, HIV. Today, Dr. Burchell will be describing the research being done to assess the effectiveness of COVID-19 vaccine in people living with HIV, along with the uptake of vaccines in I know Ontario for sure, and I'm potentially Canada. So welcome, Anne Burchell.
Thank you very much, Sherry. There, so I trust you can see my slides. So I am going to be talking about COVID vaccines among people with HIV, and I'm also going to go back a little bit higher up to talk about COVID-19 and potential impacts it's having among people living with HIV more broadly, really picking up with what Dr. Dziadzio spoke about. So there's a number of questions of how we might be thinking that the COVID pandemic is influencing people living with HIV. And one of them is fundamentally, are people living with HIV at greater risk for COVID-19 compared to people who are HIV negative? So I'm going to talk about that a little bit. The emerging evidence doesn't seem to suggest that people living with HIV are at greater risk of catching or acquiring SARS-CoV-2, but there is emerging evidence to suggest that if SARS-CoV-2 is acquired, that there is a higher risk of more severe COVID-19, such as a higher risk of mortality due to COVID. These are data from a really large study that came out of the United Kingdom that found a higher rate of COVID mortality among people living with HIV in blue compared to people not living with HIV in red. And it's important in these studies to be looking at the potential differences between people living with HIV compared to those who aren't, as Dr. Dziadzio was alluding to and talking about. So in this particular study, they did a really good job accounting for differences, such as due to age and sex, comorbidities, ethnicity, obesity, a number of different things, and still found this persisting higher risk of mortality. And this is coming out in a number of studies. Also, emerging evidence that people living with HIV are more likely to be hospitalized with for COVID-19, and in particular, a very large study that came out of the United States, their national COVID cohort collaboration, finding considerably higher risk for severe COVID, severe symptomatic COVID, as well as hospitalization. And again, these researchers in the US were able to account for a lot of the differences between people living with HIV and those who are not. In that same study, they had very large sample size. They were able to look at characteristics of people living with HIV and what was associated with more severe COVID, and found that CD4 cell count's quite important. So for people with CD4 cell counts below 200, there was about a threefold or higher risk of more severe outcomes compared to people who had a CD4 cell count above 500. Now, another important question is about how this pandemic is impacting HIV care engagement. And we know from a number of jurisdictions around the world, including high-income countries like ours, that there have been declines in HIV antibody testing and reported new diagnoses of HIV, and that have been happening since the declaration of these public health emergencies. We also know there's been a switch in how HIV care is delivered. Like a lot of all healthcare, there was a switch away from in-clinic to virtual and telemedicine care. And in higher income countries, the data seems to be suggesting that for many people living with HIV, they were able to stay engaged in care and keep getting prescriptions for antiretrovirals. But we need to continue to look at that and look at that in our own backyard to see whether what are the benefits from the switch to virtual care that might be the silver lining of COVID that we retain going forward, and what are the possible areas where people fell through the cracks. Certainly, we know there may have been, and there likely are, harms from delayed care. So in particular, for people living with HIV or participating in the Ontario HIV Treatment Network cohort study, about 18% said they have delayed their HIV blood work, and close to 10% are reporting that they've delayed primary care. So that's something we really have to explore going forward. Another very important aspect, I'm now coming around with COVID vaccines, is are people living with HIV getting equitable access to COVID vaccines? And the data so far suggest that there hasn't been a barrier for people living with HIV to get access to the vaccines if they want them. Again, data from the Ontario HIV Treatment Network cohort studies suggests that about the same proportion of people living with HIV had 2 doses of COVID vaccine by October as the general population of eligible adults in Ontario, which was about 85%. So are these vaccines going to work? So we're looking at data coming in from around the world about this. Certainly there are data from our own country, data from Ontario and also BC and in Quebec that are suggesting that there's great promise of these vaccines being effective. So vaccine effectiveness being how do the vaccines work in the real world to prevent the outcomes they intend to prevent. Data from Ontario, Quebec, and BC are suggesting high vaccine effectiveness against severe COVID, hospitalization for COVID in the general population. You have to be mindful, there hasn't been evidence yet of waning against severe COVID, starting to be evidence of waning against infection with SARS-CoV-2, but still vaccine effectiveness in Ontario has stayed above 70% to date. What we don't know yet is an estimate of vaccine effectiveness among people living with HIV. And that's really important to look at, to really measure, will they work as well for people living with HIV as they do for the general population? So in Ontario, we've launched a study called the CHESS study, which stands for the COVID and HIV Evaluation of Serology and Health Services. And it's going to look and try and get data to answer all of the issues that I've brought up. Among its aims, we want to look at the burden of SARS-CoV-2 infection and COVID outcomes among people with HIV and compare them to people not living with HIV, look at pandemic impacts on HIV care engagement and other health services, look at uptake of COVID vaccines and see are there any signs of hesitancy in the whole population of people living with HIV in Ontario, and how well do these vaccines actually work? And to look at vaccine effectiveness, we're teaming up with colleagues in British Columbia, and that's being done as part of the CTN's COVAX HIV study. So we're going to be able to look at health administrative data for 23,000 people living with HIV in Ontario and 9,000 people living with HIV in BC to actually measure vaccine effectiveness in people with HIV. And we want to not only compare that to people who are HIV negative, we want to, insofar as the data will allow us to look at things like, is it equally effective across ages, by sex and gender, and by other clinical characteristics important for HIV, like CD4 cell count. We want to be able to explore vaccine formulations and dosing, and of course, everyone's concerned about variants of concern. We think we'll have preliminary estimates of vaccine effectiveness as soon as spring 2022, and we'll update that into 2023. So I guess I'm suggesting please watch this space. The data emerging to date, to summarize, do suggest that people living with HIV, if they acquire SARS-CoV-2, may be at higher risk for severe COVID, particularly if they have a low CD4 cell count and comorbidities. Changes that the pandemic has created in HIV care. There may be benefits for telemedicine for some to keep them better engaged, but we have to be mindful and monitor going forward. Have there been deleterious impacts that we need to bring people back into care? And of course, we want to make sure that COVID vaccines work as well for people living with HIV as in the general population. So data is coming from Canadians to answer this in the near future. With that, I will thank you and thank the CTN for giving me the opportunity to speak today.
Thanks so much, Anne. We really appreciate your talk. I know they're short, to the point little talks, but hopefully we'll have a good amount of time for discussion as well. Okay, well, thanks again, Anne. And I'd like to welcome our next speaker, Dr. Cecilia Kostiniak. She's also a CTN investigator within the Clinical Care and Management Core, and she's an associate professor in the Division of Infectious Diseases at McGill University. She's also an associate investigator in the Infectious Diseases and Immunity in Global Health Program at the McGill University Health Center. Cecilia is going to be describing the research that's being done to assess the effectiveness of the COVID-19 vaccine in people living with HIV from a more of a basic science and immunology perspective. So I'd like to welcome Cecilia.
Thank you, Sherry, for the nice introduction, and thanks to the other speakers for their very nice talks. So living in Canada today are 67,000 people with HIV. And I think, as we all know, people with HIV are extremely diverse in many ways, from age, ethnicity, comorbidities, belief, and so forth. And thanks to antiretroviral therapy, people living very long. This also develops for severe COVID disease if they do get the COVID infection. So everyone living with HIV knows that the CD4 cells are important in the body because these are the primary targets of HIV, and they're rapidly depleted in initial infection. When ART is given, hopefully the CD4 count will recover, but we know sometimes that the CD4 cells will not remain as functional as in people without HIV. And when the CD4 counts don't recover, sometimes this can compromise response to various types of vaccinations like influenza, pneumococcal disease, and hepatitis A and B vaccine. That a lot of people just don't bring up their CD4 counts with antiretroviral therapy, especially as when they're older in age and they've been infected for a long time. So these can sometimes be called immunological non-responders. So in terms of COVID-19 and HIV, a big knowledge gap is whether people with HIV will mount a good response to the vaccination. And because COVID hit us all rather unexpectedly, there's a lot of questions that remain. So with other vaccines, we sometimes have to give people with HIV more vaccine doses, higher doses, or adjuvants to get the same vaccine response. And we also don't know if the antibody response, which is elicited, will last as long in people with HIV compared to people who don't have the infection. So to try to get a hold of a better knowledge of this, to guide guidelines and so forth, the CTN response was to develop an immunogenicity study, which is an observational cohort study, including people across Canada. So there's 4 main recruiting sites. One's in Montreal, one's at the Ottawa Hospital with Curtis Cooper, one's at UHN with Sharon Walmsley, and one's at St. Paul's Hospital with Mark Hull and Marianne Harris. And for this study, we have a very broad recruitment criteria to try to hit upon some of the things the other studies were lacking on, such as including people who were predominantly the ideal kind of person without many comorbidities, with a young age. And as we know, these people don't represent a lot of the people living with HIV in Canada or other parts of the world today. So with this study, the primary objective is to see what proportion of people who do get either 2 or 3 vaccine doses will mount an adequate antibody response. And we have to keep in mind that we're using this as a correlate of protection, the antibody level, but even to this day, we still don't know for sure what antibody level is necessarily considered adequate to protect against COVID-19, and if necessarily the level is the best measure, or if it should be some other marker of immunity. But for now, that is what the literature is suggesting to measure. So with this study, so first I should also say as well that with this study, recruitment is very, very broad to try to reflect a lot of people living with HIV in Canada today. We also have some quotas to try to really have recruitment in groups previously underrepresented in vaccine studies, including people over the age of 55, people who are immune non-responders, so who have a suppressed viral load but a CD4 count under 350, and people with multimorbidity, meaning 2 or more medical comorbidities. We also have a recruitment quota to have a sufficient number of people with HIV who are, quote, healthy or stable people with HIV who don't have these extra comorbidities and who have a CD4 count over 500 to try to represent, if you could say, a healthier profile. When people sign up for the study, they undergo full written informed consent, and the study is explained to them. So it involves up to 5 study visits spanning over a year to a year and a half. This is ideally at baseline before vaccination, a month after the first dose, and then 3, 6, and 12 months after the second dose. In response to the new booster, which many people have already got, we've also incorporated the possibility to have instead some study visits at 3, 6, and 12 months post third dose for the people who do get the third dose. And in response, we drop one of the visits from the schedule for people who are only receiving 2 doses. People complete, we get information on medical history, medication, ARV history, history of COVID infection, and then we also collect information from the Canadian Immunity Task Force questionnaire on COVID-19 so that we can be consistent with other groups in Canada studying the same phenomena. So patients at each visit undergo a blood draw, and with this, we're able to isolate PBMCs or peripheral blood mononuclear cells, plasma and serum. And then these are stored into a biobank. There's also room in place of this protocol for patients to inform the coordinator if they do get signs of flu-like illness or infection. And if that is the case, they're instructed to undergo a COVID-19 test. If it's positive, they're mailed a saliva collection kit, and then we can monitor for any evidence of breakthrough infection. So in terms of the laboratory study, so Marc-André Langlois from University of Ottawa is leading the study on the COVID-19 antibody levels. So we're looking at the antibody to the spike protein, the receptor binding domain, and the nucleocapsid protein. So we can tell who has antibodies due to actual vaccine response versus antibodies due to natural infection. Mark Brockman has developed assays where we can look for antibodies to variants of concerns, which can be rapidly to account for new variants, as we're currently finding in the present situation. And they're doing neutralization assays too, which is another form of measurement to see how to test a person's antibody function. And as we all know, for HIV, cellular immunity is also very important. So we have a group of people who are studying various aspects of cellular immunity, including Ali Janabian at UQAM, who's looking at different types of CD4 cells and as well as various cytokines they secrete. Mark Brockman and Sabrina Brume, who are looking at different T-cell responses. Mario Ostrowski, who is also involved with that group, as well as Jean-Pierre Routy and myself, who are looking at various cytokines and markers of gut microbial translocation, given that we know that a person's state of chronic inflammation is important to vaccine response and other immune response. So with all the data we get, we've had many meetings with our group, and we're very grateful to Dr. Joel Singer, who's been very instrumental in helping to develop an analysis plan. So we're going to be comparing all the data from our study of people with HIV compared to participants, in the Stop the Spread Ottawa cohort. This is a group of 1,000 people who do not have HIV, but who are undergoing the same procedures and blood tests as the participants in our study, and these people will serve as controls. So we're going to present all our data stratified for important variables. So as we know, men and women or males and females have different immune responses to vaccines and to infections. So we're going to stratify results based on sex. We're also going to look at results based on age. We're going to also consider the manufacturer of the vaccine which the patient got. And we're going to also be comparing people who got 2 vaccine doses versus 3 vaccine doses to see if there's any difference there. And all of this information will be, anonymized. They're coded numbers, and we'll share some of that information with the CITF, the Canadian Immunity Task Force, so that this can also be used to inform knowledge and guidelines for other groups studying the COVID-19 pandemic. And in terms of participant involvement, it's very important to us that the participants feel that they understand what's going on with the study. So in addition to all the knowledge dissemination events we're doing, each participant is going to receive their antibody levels with a description in lay language of what the meaning of that is. And they'll get a description of the results for the whole study. So they'll know how their antibody levels compare with that of other people who participated in the study.
And ask you to wrap up now.
Yeah, great. Okay, and in terms of knowledge translation, we're going to, in addition to KT, we're going to do a lot of knowledge sharing and data dissemination with groups who are prominent for producing guidelines, such as NACI, National Advisory on Immunization, the Vaccine Surveillance Research Group, and National Advisory Committee on Immunization. So I'd like to just thank all the large number of people who are involved in this study, because it could not be done without this huge team effort. Thank you.
So it's my pleasure to introduce our final speaker. Our final speaker is Dr. Rupert Kaul, also a CTN investigator within the Vaccine and Immunotherapies core. So we've covered most of the cores today. He's a senior scientist at the University Health Network of Canada, a professor in the Department of Medicine at the University of Toronto, the director of the Division of Infectious Diseases at the University of Toronto and the University Health Network, and an attending physician at Toronto General Hospital. Today, Dr. Kaul is going to discuss the latest developments in pursuit of HIV vaccines, as well as the possibility of a functional cure. Welcome, Rupert.
I will try and talk a little bit about whether COVID can teach us anything about HIV cure or vaccines. And I think it's good that I'm last and that I don't have that much time, because I'm not sure that in terms of biology, COVID is going to teach us actually all that much about these. So in terms of HIV cure, I'm not sure that COVID really is going to tell us much about HIV cure at all. In terms of HIV vaccines, I think that's where people think there may be a little bit of overlap, and that the real tremendous success we've had with COVID vaccines may help us develop HIV vaccines. I might just give a little bit of a reason to think twice about that, although I do still think that there is a little bit of hope that that may be the case. So the main reason I think why COVID is not going to teach us very much about HIV cure is that COVID is very different to HIV in terms of what happens when we get infected. So the big problem, of course, with HIV, and I think everybody on the call knows that, is that HIV can make these latent reservoirs where you have cells that are infected for a very long time by a latent virus, and that virus can emerge later. That's what makes it so difficult to cure HIV. We really don't have that issue with COVID. So, COVID either kills you or COVID gets cleared by the immune system, and we don't have this same issue of the latent reservoir. This table here is just from a presentation talking about HIV cure and latency, and saying, hey, these are all the different kind of cells that HIV can infect, and we're not even sure as researchers exactly which types of cells that latent reservoir is within. But we don't have that problem with COVID. However, there has, just out of interest, it's not really directly related to COVID, but there has been a case described in the last year. I think many people will know about the Berlin and the London patients. These are people who have been cured of HIV after getting a stem cell transplant, so quite a dangerous medical procedure. There's been a description very recently. It actually says it's coming out in 2022, but obviously it's been published already online. This Esperanza patient, and this is a woman who had an HIV infected male partner, and what was seen was that if you just look on this figure here, you can see that her CD4 count was going along at a normal level, and then suddenly that CD4 count went down, and the HIV test became positive, but they were never able to find any virus in her. And she actually became pregnant and had a baby, and during the pregnancy was on antiretrovirals during the pregnancy. And they have examined both the placenta after the baby was born of this patient, and also they have taken a huge number of cells from the patient through this process called leukapheresis, getting a very large number of CD4 cells. And they've not been able to find any virus that is able to replicate, any functional virus at all. And so this does seem to be somebody who has been able to clear themselves of replication competent, of functional HIV virus, without a stem cell transplant and without any specific treatment, which is very interesting, and that patient's still under very active investigation. Most of the rest of the time when we're talking about HIV cure, we're talking about, and people have probably heard these terms before, please don't pay too much attention to the figure, but this shock and kill, which is where you try and wake up virus from these latently infected cells on the left with these LRAs. So these are latency reversing agents that wake up the virus in those cells, and then we would come in with various strategies to mop up that virus. Of course, if we don't have any latent virus, we don't need that, and therefore the strategies that have been designed to treat COVID are not really relevant for this. And we're talking more recently about this block and lock, and it's quite fun because, when you're talking about HIV cure, this is obviously exactly the opposite strategy. So this is talking about trying to promote that virus that is latent within our cells to be super latent, so that the HIV within our cells never emerges from the cells and gets locked into those cells. But again, not an issue that we have with COVID, and therefore I'm not sure that COVID is going to teach us too much about HIV cure here. So what about vaccines? I think, my main message here is that unfortunately, a strategy that works for COVID does not necessarily mean that vaccine strategy is going to work for HIV. And I have two of the sort of efficacy figures from two pretty well-known papers. So on the left here is the paper from the AstraZeneca vaccine. And lots of us will have heard about the AstraZeneca vaccine because it was the one that tended to cause blood clots, so it's actually not being used in Canada anymore. But this is data from the trial, and what you see is people who got the blue vaccine, that was actually a vaccine that was active for a different infection, not COVID, they had a much higher rate of getting COVID than those who got the orange vaccine, and that was a COVID vaccine with an adenovirus. It was an adenovirus-based vaccine. So they put COVID genes inside this adenovirus, and that was quite an effective way of making immune responses against the adenovirus, and very protective. Those two lines are very different. That's showing you that the vaccine protected. Now, we actually tried using an adenovirus-based vaccine for HIV a while ago, and here's from the Fambili trial. This on the right-hand side, this was a trial done largely in South Africa where they were using an adenovirus-based vaccine. And here you have the opposite. So an HIV genes put inside an adenovirus as a vaccine strategy, we actually see that here, those who got the vaccine had higher rates of HIV, significantly more so than those who got the placebo vaccine. And so clearly a strategy that worked very well for COVID was not at all successful for HIV. Something similar we see when we're talking about these monoclonal antibodies. So people may know that now you can, if you come in with very early with very early COVID, we can actually give you a monoclonal antibody, so a pre-made antibody. And if that is even given before you're exposed to COVID, there's some data coming out from AstraZeneca, although I can't show you a picture because it's not been published, saying that giving these monoclonal antibodies is a very good way of preventing COVID if you give somebody that antibody in advance. Unfortunately, in HIV, where we've been able to find some very effective monoclonal antibodies, the figure here is showing you that these lines between placebo and getting the active antibody, we don't really see much protective efficacy with that antibody at all. So again, quite different between COVID and HIV. So why is that? I think the main problem is that we don't know what the best immune response is that we want an HIV vaccine to induce. And we do know that with COVID. This figure here is just showing you that the higher the level of antibodies that you make against spike, which is that outside part of the COVID virus, the more effective your COVID vaccine is. But unfortunately, we don't really know what the best immune response is that we want our HIV vaccines to make. And therefore, even with the new RNA-based vaccines, which is a totally new kind of vaccine where we've been using it really for the first time in a large scale for COVID, again, I'm not sure that using an RNA vaccine is going to give us success necessarily against HIV just because it was effective against COVID, although I'm very interested to see how those vaccine candidates work. And we are going to be trying those vaccine candidates out. So overall, I'm not convinced that COVID is going to teach us all that much about HIV in terms of HIV cure or vaccines. It obviously does teach us a lot about HIV, and it has a lot of relevance for HIV, as we've heard particularly from Pascal earlier, in terms of the populations that are most affected and ways to, outside of the biologic treatments, ways that we can help to reduce risk. And the main reason is that SARS-CoV-2, the virus that causes COVID, doesn't hide. It either kills a person, rarely, or it gets completely cleared. And really, it's been too easy to make a COVID vaccine. Many different strategies have worked very well, and obviously COVID is a very different type of virus to the HIV virus in terms of what we need to do. So the last thing I just want to say, as I go is, in some ways, compared to when I was a kid learning about treating HIV, it seems to me as if we already have, to some degree, a functional HIV cure. I'm a doctor. I just had to get my booster of the COVID vaccine because 6 months after I got my last one, my antibody titers were already waning, so you have to go get another one. Well, we now have these injectable HIV medications that are just now covered by ODB here in Ontario, at least. And this is now injectable medications that I get every 2 months. At the first, it was every 1 month. Now it's every 2 months. So I'm really hoping that we will very soon have injectable medications that we can give where somebody can come in and get an injection every 6 months, perhaps. And that seems to me that would be very similar to what's happening in terms of, for me anyway, in terms of having to have my booster of the COVID vaccine at 6 months to have effective protection against COVID. So in some ways, I know it's not a functional cure, and I know we still have a way to go, but we're certainly moving in a direction that's almost a little bit like a cure. If you're getting an injection every 6 months and that's all the treatment that you're needing to take, I think that would be a huge step forward. So okay, that's all that I had to say. So thank you very much.
Thank you so much, Rupert, and thanks for keeping with our time. We have asked our guests if they could stay a few minutes longer so we could have some questions. This is a question from Devin Nambier, who's on our Community Advisory Committee at the CTN. And the question is, what's the current consensus on the efficacy of tenofovir with or without FTC in reducing severe COVID illness in people living with HIV or an HIV negative on PrEP? For people living with HIV, is the outcome dependent on CD4 count?
Sounds like a good question for Cecilia.
Cecilia?
So yeah, no, that's a great question. I know for sure, even at our clinic at the beginning of the pandemic, we were very interested in this, news about tenofovir, because there seemed to be maybe some suggestion that people were less at risk, but it turns out that isn't really the case. And we haven't noticed any correlation with that anymore. And I think people have kind of dropped off that idea that it is protective in any way. So Yeah, but at the beginning, it did for sure spark a lot of curiosity, but it hasn't panned out to show that it's any type of protection.
Thanks, Cecilia. Aslam, I believe you had a question?
Yeah, I had a question. Thank you, everyone, for your great presentations. They were all excellent. I had a question for Rupert when Rupert said that I'm a doctor and I had to get a booster shot because my antibody was waning. What does that mean for you getting COVID if you didn't take the booster?
Well, there are some good studies now demonstrating. I mean, the best study really was done in older people. I'm not quite 60 yet, but I'm not that far off. And it was in people over the age of 60 in Israel. We'd known for a while that the closer to, you know, when we were first giving out that Pfizer vaccine, it was supposed to be 3 weeks apart. And we actually now know that you might even get a better antibody response if you stretch that out a little bit. That's why we are stretching it out a little bit more in Canada. But essentially what happens is you would get a big boost of antibodies, and then they would gradually fall off over time. And there had been some concern about maybe when that happens, you'll be more susceptible to get COVID again. And the very well done study done in Israel, where they've been a little ahead of the curve in terms of getting out the vaccines and monitoring these things, showed that in people over the age of 60 who had got 2 doses of the vaccine, those who then got a booster, at least 6 months afterwards, their rate of getting COVID infection was about 10 times lower, and their rate of getting severe COVID was even lower than that, or there was an even greater impact on getting severe COVID, although those rates were still relatively low. And again, I think those original 2 vaccines were still providing protection, but by getting that booster of the vaccine, there was very clear evidence that you had additional benefit with that booster. Of course, one of the big arguments that we're having globally is it more important that I and everybody else get that 3rd dose of the vaccine, that booster dose, to get some more protection when my risk is already low, or should we be using those doses of the vaccine globally to make sure that everybody gets their 1st doses of the vaccine, which is not the case, right? And I think that's a very big debate that we're having globally right now.
Yes, thank you for bringing that up, Rupert. I attended the Canadian Global Health Conference on HIV or it wasn't on HIV, Canadian Global Health Conference last week, and that was certainly a very active topic of discussion in the breakout rooms. So thanks for bringing that up. Are there any other questions from the floor? I have one question here for Dr. Giadu. When it comes to race, I apologize for my dog. When it comes to race and or culture as a social determinant of health, how different are the needs of each community, or are there universal similarities in the barriers to adequate care?
Thank you for the question, Sherry. I mean, when it comes to addressing these issues, it's very important not to generalize, because each community will have its own specificity and its own cultural differences. So, and we saw the little chart showing how COVID impacted the ethno-racial factors, you know, in COVID impact in Toronto. And you clearly saw that all these different ethnic groups, the impact was a little bit different. So meaning that, you know, it's going to be very hard to generalize this impact or addressing this issue based on generalization, right? So I think each community and each cultural differences has to be taken specifically into consideration. Yeah.
Thank you so much for that answer. And we have one last question coming from Mark Segan. Are there, and this is for whoever would like to take it on, are there any considerations regarding the Omicron strain and people living with HIV, or is it too soon to tell?
I can probably answer that. So yeah, so Omicron was, I guess, reported in November. So and we know that the mutations so far are in the S spike proteins. So the good thing, at least, is that our vaccines do protect against, you know, those types of mutations. It is a bit early, though, to tell. However, in South Africa, they have very sophisticated surveillance networks to monitor viral evolution and HIV mutations and vaccine effectiveness. So there's definitely work ongoing. I think, though, in Canada, like for us, the big thing is to be sure everybody is vaccinated. There's still, unfortunately, a population of people who are vaccine hesitant. And from what I understand with Omicron, a lot of the cases they're seen in South Africa are being seen because a huge amount of the population, like over 70%, I believe, or a very sizable amount people are not vaccinated. So it is very soon to tell. I think the biggest thing is to, encourage everyone to be vaccinated if they aren't already, and continue just, the social distancing, hand washing, mask wearing. And if people do that, I don't think there should be a problem, at least, not in Canada. It's too soon to know if it is more transmissible, and it's too soon to know if people do get sicker from it or not.
Thank you, Cecilia. Aslam, I'm going to give you the final word since I see your hand up.
Okay, thank you. I just was going to ask a question related to some of the questions here to Anne. And your study sounds so fascinating with 23,000 people. Obviously, you'll have people with different backgrounds and different socioeconomic status. Will your study be able to tell us any of these things about access and effectiveness in different populations?
It will in part, perhaps not as completely as we would like, but certainly the data from Ontario, which is at ICS, and in British Columbia, there's neighborhood level information. And so one can by proxy look at characteristics of neighborhoods to look at measures related to social determinants of health. And then within Ontario, there is a subset of the population that we will have access to that are volunteer participants of the cohort study, the Ontario HIV Treatment Network cohort study that I gave some data about. And given their annual interviews, it's actually quite rich data about sociodemographics, HIV characteristics, social determinants of health. So, and there's estimated to be around 4,000 people actively participating. So for a subset, we'll be able to look at that.
I'd like to thank all of our speakers. I'd like to thank the CTN for hosting this event. And I'd like to thank all of our participants for commemorating World AIDS Day with us today. I hope you all have a wonderful day full of joy and reflection. And I wish you all the best today.